Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Jenny Berkovich, board-certified pediatrician and director of education for JOMA. Today's episode is our second part in our series with Dr. Suzanne Hagler on pediatric migraines. If you didn't get a chance to listen to the first episode, I recommend doing that first. This section focused all on treatment options, so it's important to have a good background before you hear this part. As a reminder, Dr. Hagler earned her medical degree from the Albert Einstein College of Medicine, completed a residency in pediatrics at Jacobi Medical Center in the Bronx, followed by a residency in pediatric neurology at the Albert Einstein College of Medicine. She then pursued a clinical fellowship in headache medicine at Cincinnati Children's Hospital Medical Center in Ohio. After fellowship, Dr. Hagler spent 7 years working at Nicholas Children's Hospital and serving as their director of pediatric headache program. She now owns and runs her own private practice, South Florida Headache MD in Hollywood, Florida. She continues to be affiliated with Nicholas Children's Hospital. Welcome back, Dr. Hagler.
So I feel like the arsenal of tools that you have for prevention is pretty large. That makes me think that maybe you don't need such a large arsenal of tools for treatment, but I suspect that's not true. Tell me a little bit about what options we have for treating actual headaches.
So when you get a headache.
When you get a headache. Yeah.
Yeah, sure. So the mainstay of treatment for acute treatment of migraine, first line is going to be your over-the-counter medicine. So NSAIDs, like the non-steroidal anti-inflammatory medications like ibuprofen and naproxen, which are over-the-counter, work very, very well for migraine for tension type headache and for migraine in many patients. So that's going to be usually the first thing that we recommend. Acetaminophen or Tylenol for many patients works as well. Some people find that one of those things works for them and not the other. So one of the important things that I think for pediatricians to be aware of this and parents is making sure you're giving them the right dose. I see this a lot, like a full size, 13-year-old will come in saying ibuprofen doesn't work for me, but they're drinking like a little baby amount of liquid, right? And so they really need a good full size adult dose. So for ibuprofen, 10 milligrams per kilogram, for naproxen, 10 milligrams per kilogram, for Tylenol, 15 milligrams per kilogram, but making sure that you're giving them like a solid weight-based dose, not necessarily going off of what's on the bottle, which is often under for many, many kids in those age ranges. The other thing that's important, sort of as first line kind of guidance, is treating early. So the earlier you get to the headache, the better the medicine is going to work.
Which I don't think generally people do a good job of. I talk a lot about this actually when I address like menstrual pain with teenage girls. And I think pain in general, people think like, oh no, it's okay. I don't need the medication. I don't need the medication. So I always say like, by the time it's so severe, you're making it harder for the medication to actually give you relief. So counter to what you may want to do, you need to take it right when you're beginning to feel uncomfortable.
Yes, for sure. I mean, the example that I give people is of a fire, right? It's much easier to start to fight a small fire than you let the fire get big, 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 big. Your medicine, which may be a good medicine, is going to have a much harder time fighting a big, big, huge fire than it would have if the fire was too small, right? So that's the image that I try to put into people's minds. It's very understandable that that people often don't treat early. There's a few reasons that they don't. One is they're worried about using medicine too often, which I can talk about that as well. The second is a lot of times it's just like practical reasons, right? The kid is at school and they have a headache in class and they don't want to interrupt, or they don't feel comfortable saying they want to go to the nurse, or they're busy. Kids generally want to be normal, right? Kids want to play, they want to be active, they want to hang out with their friends. And so for a lot of them, it's easy enough for them to ignore pain when it's at a low level. And then if they really when they just want to keep going, which is a good thing. But then once it gets really terrible, that's when they say something about it or do something about it. And sometimes then it's too late. The medicine don't work as well. The other things I tell people to do sort of first line for any headache, what I do think is very helpful is extra fluid as soon as the headache happens, particularly something with electrolytes. So sort of similar to, I don't know if you've ever had a patient go into the emergency room for a really bad migraine, but when somebody goes into the emergency room for a terrible migraine or a headache that's not going away, one of the things that's given to them is a big bag of IV fluid. There is something about that extra fluid with the electrolytes kind of plumping up the blood vessels that helps them. And so you're kind of trying as best you can to mimic that orally. It's not going to work as well, but having them drink a few cups, 2, 3, 4 cups of a hydrating fluid. So I tell them, healthiest version of that, if you like it, would be something like coconut water or maybe Propel water, like a water with electrolytes that doesn't have all the sugar and artificial dyes and things like that. If they won't drink that though, or they don't like it, then something like Pedialyte or Gatorade or Powerade will help a lot of patients in that acute setting. So kind of like first line for people without even going to prescription, all of those things are very helpful. The issue to think about always in the back of everybody's minds is what we call medication overuse or rebound headache, right? So that idea that if I take too much of this medicine, is it going to stop working? Is it worse? So we do know that if you use a medicine too frequently, and too frequently depends on what the medicine is. So each medicine kind of has their own rules for what's been shown to be more likely to cause medication overuse headache. For the over-the-counter meds like ibuprofen, naproxen, Tylenol, acetaminophen, generally 2 to 3 times a week is what's considered to be like in the safe range. You probably don't want to do that long term anyway, right? So like, I'm not going to tell you to take ibuprofen 2 to 3 times a week, every single week forever, right? Because you still in that frequency, maybe starting to run into side effects, GI issues, gastritis, things like that are probably not good for you. But in the short term, and if somebody's needing medicine that frequently, then that is a patient who you're thinking about prevention for anyway, right? Because they shouldn't be needing acute meds that often. So that's a sign. But especially like in the acute, in the immediate setting while you're getting the headache under control, 2 to 3 times a week is kind of a safe range that should not be making their headaches any worse, right? So that's kind of, I tell them that. And then depending on the patient, you're going to cater to how early you tell them to treat, right? So like they have a headache every single day and you're telling them to treat early, that's hard, right? Because then which ones do you treat? So that's, where you get into kind of like the art of the whole situation. But if somebody's having a headache once or twice a week, I would rather them be aggressive, treat early, and be more likely to completely eliminate that headache than let it kind of linger long. Then you take your medicine 6, 7, 8 hours in. It helps, but the headache's still kind of there. Then they may be more inclined to take the medicine again the next day. It helps too. Maybe it went away, maybe it didn't. And that's where you start to get into that pattern that you don't see. So again, it's kind of, towing that line between too much and also treating early. And it really depends on the patient. So over the counter stuff, that's really what we're, using first. Prescription wise, triptans are migraine specific medicines that have been around now for many years. And those are medicines that are used acutely to treat migraine. So the most common one that most people have heard of is Imitrex. That's been around forever. Again, there is a lot of confusion, I think, in general, amongst people for what those medicines are used for. I've seen people come to me who have been told to take Imitrex every day, or, like people don't really know, I think, a lot of the time how to use these medicines, but they are acute treatments. They're meant to be taken when you get a headache. Triptans are some of them FDA approved in kids. So the one that I typically start with is rizatriptan, which the brand name for that one is Maxalt, because that one is FDA approved down to 6 years old. So we do use those again with kids. But there are 7 medicines in that class, and we use all of them. The other thing to know about the triptans are some of them come as a nasal spray, some of them come as an ODT, like an oral dissolving tablet. And so for patients who either can't swallow pills or have vomiting with their migraines, and so they maybe are not going to keep down a medicine, administering it that way will be better.
Are there any other medications that are useful for breaking a migraine episode?
Yes. So I would say those are kind of the mainstay that most patients, and so in terms of, first of all, going back to the medication overuse or rebound headache, triptans also can cause that problem if you use them too often. Typically, studies have shown using them more than 10 days or more per month can cause that. I usually tell people to try to stick to 6 days a month, kind of thinking about how often am I okay with using this medicine, how frequent are your headaches right now? And then I'll tell you, because the over-the-counter stuff can be used a little bit more frequently. Maybe you start with that first if it's not that bad. Maybe if it's really bad, you start with both at the same time. You can take them together. So there's different ways to. Outside of those two main categories, we use some of the antiemetics. So those are the anti-nausea medicines. Those can be used for acute treatment of migraine as well. So first of all, as we know, many patients with migraine have nausea as part of their migraine. So if nausea is a piece of their migraine, regardless of whether the other medicines are working for their headaches, we often use Zofran, which is ondansetron, to treat the nausea piece, which can be very, very helpful to help with nausea and prevent vomiting. The Zofran in and of itself doesn't really help with the pain of migraine. So that's okay. But I think that's also a confusion that some people run into. So Zofran will help with the nausea. It's not necessarily helpful for the pain piece and the rest of the migraine. There are other medicines. So most commonly we use prochlorperazine, which is colchicine, or metoclopramide, which is Reglan. Those are medicines that are often used intravenously in the emergency room. If somebody comes in with a severe headache, they can be given by mouth as well. And so for some patients, we will add that on to their regimen. And those, even though they're anti-nausea medicine, so first of all, they will work for the nausea piece too. They also, because of how they work in the brain, will work on the pain piece of migraine as well. And so for patients who need it, we'll add that on. I start to worry more about long-term side effects of using those medicines. I'm a little bit more hesitant to use them on a long-standing basis because they're actually, even though they're antiemetics, like anti-nausea medicines, they're actually in an antipsychotic category of medicine. And so similar to other antipsychotics, there are rare occurrences of things like dystonic reactions and even tardive dyskinesia, which is like a chronic movement disorder that can develop from using those types of medicines too frequently. So I personally don't use them a ton, but I do when other things are not working. Sometimes often combined with other treatments. They also work extremely well IV, and they don't work that amazingly for people by mouth. So we use them sometimes as an adjunct, but it's not kind of my first line. The other thing to be aware of is in that same class of newer migraine medicines that are out there for prevention, there are also two that are in that same category. They block CGRP, but those are pills that you take acutely when you get it. So those two medicines, one of them is called Nurtec, the other one is called Ubrelvy. Again, a lot of people are hearing about them now because there is a lot of celebrity endorsement actually of some of them. So people are seeing them, but those are used acutely. They also work really well for many patients. Similarly to the preventives, they're not FDA approved yet for patients with routine. Expensive. The insurance companies want to see that you've tried a lot of other things first before you go to them, but they do work well for many patients and they are very well.
I want to switch gears a little bit and talk about what we actually need to do to make one of these diagnoses, or rather what we need to do to rule out some of the other stuff that may be worrisome. We talked a lot in the beginning about the clinical criteria for migraine, certain things that you need, certain experiences that we want the patient to be having before we properly, either call it a migraine, attention, or neither, or maybe both. But I find that patients often expect that we right away will do imaging, right? Well, right away we'll get a CAT scan or an MRI as part of our workup for headache. Why is that not necessarily the case?
So for many patients with recurrent headaches, we will do imaging, right? So I think there are two reasons to consider imaging. One is one of the red flags, which I can go through what those red flags are. And then also sometimes for peace of mind, right? that's not the by the book answer that we're supposed to give, but sometimes it doesn't matter what you tell them. The parent or sometimes the kid is not going to feel better until they have had a picture of the brain and they know that there's nothing. So sometimes I think it's not necessarily wrong to do that if we think it's now. The flip side of that is, and I warn people about this before we do any kind of imaging, it's very common to find what we call incidental findings. So when we do an MRI of the brain, we take a very detailed picture of the brain. We almost never find something that's causing headaches. However, very frequently we'll find other little things. Little bright spots are super common, and we don't know what they are. They actually seem to be a little bit more common in migraine patients, but patients without migraine don't have them. They're not considered a diagnostic criteria or anything like that. We just know they're common. We think that they may be signs of maybe some little bit of meiosis or scarring that may have happened at some point, even in utero. We really don't know what they are, but they're common. If you took an MRI of people on the street, you're going to see little changes like that in a lot of people. I kind of tell people it's almost like having friends in your brain, right? Like you just have that. But they can sometimes be a little difficult to distinguish from maybe something else, right? Is it possible that we, very accidentally, luckily stumbled onto some other rare genetic disorder that's like in the beginning stages and hasn't caused symptoms yet, but we were lucky enough to do some MRI for something else and we see these, right? So like your brain goes to all these places and it's hard to reassure people at that point, like, no, this is just their brain. It's okay. So we have to prep them that may come up. We also often find things like cysts, arachnoid cysts, pituitary cysts. Those are very common and typically don't cause headaches. And that's hard for people to accept.
It's really hard because when you see an MRI finding, right, of your brain or your child's brain and there's a cyst, like that's scary, right? That's not something you think you like want in your brain. And so it's hard to,
100%.
right?
Yeah.
It's hard to like rationalize and to be like, okay, it's nothing. Well, how could it be nothing? There's a cyst in my brain. That doesn't sound like nothing. And I'm having headaches. Surely the two are related. So I just want to emphasize that, like that compassion around like how difficult it is to accept that they are in fact
really,
not related.
Really difficult. Yeah, I'm having pain and you're telling me this fluid-filled sac in my brain is not the cause of it. Like, why would I believe that, right?
Right.
I try to explain to people, and this is our understanding. And again, there's still things we don't know, right? So, but our general understanding is actually the brain itself is not a pain-sensitive structure. If I touched my brain, like just the brain itself, the inside, you actually would not feel pain. The things that are pain sensitive in the brain are actually the blood vessels. So like the coating around the blood vessels are sensitive to pain, like have pain receptors. And the meninges, so the coating of the outside of the brain have pain receptors and are sensitive to pain. So for something to be causing pain in the brain, typically it needs to be big enough that it's causing things around it to really shift and move to a significant degree. So causing what we would call massive, right? So moving things really in a way that they're stretching the pain sensitive structures in and around the brain enough to be feeling pain, or where they are not necessarily that big, but in an inopportune spot where they may be interfering with the fluid that flows through the brain, right? So everybody has ventricles or fluid filled spaces inside of the brain that are filled with cerebrospinal fluid or CSF. You're supposed to have it. That's normal. They are, supposed to be at a typical size, and your brain is frequently making CSF and absorbing CSF, and it's a system that's connected between your brain and your spinal cord, and that's we all have that. But if something happens to be in a spot where it's interfering with the fluid flowing where it's supposed to, it'll back up, and those ventricles get big and stretches everything around it. That's what they call hydrocephalus, which is a cause of headache and can cause pain. So, but again, for something to be causing pain in the brain, it typically needs to be doing one of those things. There are exceptions for that. There are a few specific locations. For example, the pituitary gland is one where it seems like even without a huge mass in that area or a huge cyst, sometimes things in that area tend to cause these kind of more rare headache disorders that we see sometimes. But that's kind of the rule. So when we do imaging, we need to warn people, listen, you feel like this is a benign thing to do. But you need to be aware that we may find stuff that I'm going to tell you is actually not the cause of the headaches, and you might worry about it. And sometimes it leads us down a path of feeling like we need to, now that we saw it, maybe repeat the MRI at some point a few years down the line to make sure it's stable, So sometimes you get into problems from doing it. It's not completely benign. That being said, if you're kind of willing to accept that, taking a picture in and of itself, when we're talking about MRIs, not CAT scans, MRIs don't have radiation, and so they're generally safe. We only do CAT scans for headaches really in the acute setting. So CAT scans are very good for looking for fractures or for blood, or for big masses or fluid backups, but they do have radiation involved, and so there is some risk involved. One CAT scan is not going to cause any harm, but we try to minimize how many times we're doing that to the person over the course of life, and so we don't do that just willy-nilly. So generally, CAT scans are done in the emergency room or maybe outpatient if you really, really, really are worried about somebody and you want to get a picture really quickly. Those you can generally get scheduled very fast. But usually if we're talking about imaging for headaches, we're talking about an MRI, which does not involve radiation. There's a much more detailed picture of the brain. It's going to show us a lot more. So typically that's what we're talking about. The other downside to doing MRIs in kids is that they often require sedation. So if it's a child or a teen who is old enough, mature enough where they can lay still for the entirety of the imaging, then there's really, when you talk about risk, essentially no risk besides for maybe finding. But if you are needing to sedate them, it's still pretty low risk. They do tons of them at the hospitals, every day, but it's not zero risk. And so you have to really, think about, is this worth it? And then there's also the kind of downside of we're supposed to think about costs of the medical system and things like that. Those are very, very expensive tests. And so should we really be doing them for no reason? We don't want to. We want to have a reason. So most kids with recurrent headaches probably don't need imaging. There are things we look for to know when to worry about this. So there are different mnemonics that people use to kind of help remember these things. I like one called Snoopy 4. So we can go through what those letters represent because it's just a little bit of an easier way to remember things. So the S would stand for systemic signs and symptoms. So if you're telling me that you have headaches and also you've lost a bunch of weight, or you're extremely fatigued, or you have any sort of other general signs of illness, that's going to make us think about, is there something else? God forbid, a tumor that's causing, systemic signs or symptoms, or, maybe another health condition, right? That could cause, poor growth, weight loss, fatigue. Again, going back to, there are not many things, honestly, that cause headache in terms of medical conditions, but things I think about are thyroid disorders, anemia, and celiac disease. Those are kind of like the main ones that I tend to think about first when you kind of see that in that picture. But again, headache plus other stuff together makes you think about other causes. The N in Snoopy stands for neurologic signs. So if you have a headache and you're getting headaches, but you also are getting double vision, numbness on one side of your body, weakness on one side of your body, you're having balance problems, all of a sudden, one of the bad cases I saw in residency was a child who, all of a sudden had terrible handwriting. They couldn't write like they used to be able to write, and they were having recurrent headaches, right? So that was a tumor in the cerebellum, which is the part of the back of your brain that controls coordination, right? So headache plus neurologic signs or symptoms. So symptoms like that, or a neurologic finding on exam, right? So a person with chronic tension type headache, migraine, any other kind of just headaches for other reasons should have a completely normal neurologic. So when you test how everything's working, it should all be working. If you have a finding on your exam that's focal, that indicates that there might be something going on in a particular part of the brain. You need pain and also the neurologic exam. One of the really important pieces of an exam, I think probably the most important in my opinion, would be actually the eye exam. So looking for something called papilledema. So it's important to understand the eyes, the nerves in the back of your eyes connect to your brain. And so if there's any reason for increased pressure in your head from anything, too much fluid, a mass, anything like that, over time, that increased pressure in your brain pushes on the nerves in your eyes. It actually causes some blurring of the nerves that we can see when we look in the back of your eyes. So a good ophthalmologic exam could be really reassuring when it's normal. If you see papilledema, that is like immediate. For me, honestly, that's like a go to the emergency room for imaging case. That's not even like an or an MRI, right? So having that, and so basically having any neurologic sign or symptom, the papilledema being the big one for headache, is important. And most pediatricians are not really trained well enough to look at the optic nerves, and that's fine. It's a hard exam to do. So for pediatricians, if that's not something that typically generally practice, for somebody having frequent headaches, having them go see an eye doctor is a very, very reasonable first step. First of all, because for some people, maybe vision is a part of it. Maybe they just need glasses, right? There are certain patterns that you're looking for in that history. When you think about that too, most of the time it's not their eyes, but it's very reasonable to have them see an eye doctor. First of all, make sure their eyes are working properly and that that's not causing the headaches, but then also to look at the nerves in the back of the eyes. And if they're normal and there's no signs of papilledema, that is very reassuring. Not 100%, but very reassuring. So that's kind of the end of the neurologic signs or symptoms. So then O stands for onset. So thinking about the onset of the migraines, kind of, we referred to this before, but did they kind of every so often you were having them and crept up over time, kind of typical migraine pattern, or did this start like boom out of nowhere? Either something called a thunderclap headache. So thunderclap headache in and of itself is a reason for imaging. So somebody who tells you they had a boom headache that went from 0 to 100 within seconds, severe pain, that is a thunderclap headache. That onset is an indication for imaging. Also, onset that is very consistently during sleep or in the early morning, that is an indication for imaging. So somebody who's telling you that they very regularly have headaches that are starting in the middle of the night or waking them up in the early morning would be a red flag. The reason being that if you think about gravity, again, if you have something bad in your brain taking up space, when you lay down, that pressure is going to get higher than when you're standing up just because of gravity and changes in your body position. And so when you're sleeping and in that position over time, it gets worse overnight. And so then that may be a time starts. And so that's considered a warning sign. So if we're typically consistently seeing that pattern, that's an indication for it. It's important to know that many patients with migraine, particularly if they go to bed with a headache, may wake up in the middle of the night still with a headache. So when you ask about nocturnal awakening, it's much less worrisome if they say, well, it only happens when I went to sleep. But we still think about it. And some patients have a migraine pattern where they start in the middle of the night. We don't know why, but that's something related to their circadian rhythm, and that's the pattern. But in those cases, we are getting imaging first to just rule out anything else. So that's one of the things. The P in Snoopy is for positional exacerbation. So a headache that is distinctly different in different positions is also a red flag for a secondary headache disorder. Now, that's also sometimes hard to distinguish from what migraine patients typically report, because patients with migraine, often their headaches are worse with movement and activity, and they report that they're better with rest, right? So it's important to distinguish between, well, yeah, when I get a migraine, I feel better when I lie down. That's not necessarily because of the position of their body. It's because they are resting versus moving, right? So, but a true positional component, so headache that's clearly very worse in this position versus in the laying down flat position versus the standing up position, or the opposite, can indicate a pressure in your brain either too high or too low. And so that's a reason for imaging. The next P, so there's 4 Ps. So there's 4 Ps, is precipitated by Valsalva maneuver. So a Valsalva maneuver is something that you do that transiently increases the pressure in your brain. So typical examples of that are coughing, like if you have like a hard cough, or yell, or like it's strenuous exercise or straining when you go to the bathroom. If you have headaches that are specifically triggered by those things, that can also be a sign of a secondary cause of pressure in your brain. And so that's an indication for imaging. The next P is progressive. So that's, again, hard to distinguish between a classic migraine pattern, right? And so, it depends sort of the period of time that it's progressed over. But if somebody tells you that they're just getting worse and worse and worse and worse and worse over time and nothing's helping them, even though, again, we kind of see that often in migraine patients happen in that qualification pattern, if somebody tells you that pattern, that it's just progressively getting worse and worse, we usually will reach for that. And the Y in Snoopy is young age. So young is considered 6 and under. If you have recurrent headaches in a patient 6 years old and under, it's an indication for imaging pretty much across the board. The reason is because, first of all, in that age, the history is much harder, right? When kids are that young, they really often cannot give you enough detail to really hang your hat on to have sort of a reassuring history. You're getting a lot of maybes, a lot of I knows, a lot of think so's. And so when the history is not so clear, you're kind of better off erring on the side of caution. The other thing is that when they've looked at this, secondary causes of headaches have been shown to be higher in that age. So we know that causes of secondary headaches are a little bit more common in that age group. And so we're just a little bit more likely to kind of pull the trigger and get imaging. There are two other signs that have often been considered to be red flags for imaging, but when they've looked at this more recently, it seems to like the association is like pretty weak. And so it's kind of a soft call, but two things that have also been considered you think about imaging are occipital location. So when the headaches are pretty much mostly in the back, that's an indication for imaging. We know that actually many people, migraine can be in the back, in the occipital location. So that's some people's migraine, how it presents, but it has been associated in some studies with having, masses in that area and things like that. And so headaches that are primarily in the back of a head is an indication for imaging. The other thing is completely side locked headache. So a headache that is always, always on the same side. So migraine in general is often unilateral, meaning often on one side of the head. But the classic migraine unilateral pattern is people will say, well, it's usually on my right. It's almost always on the right side, but sometimes it'll be on. Every so often I get a headache that's on both. That's kind of classic migraine. In younger kids, actually, migraines are actually more commonly bilateral, meaning they're more commonly on both sides, actually. So you see that unilateral pattern even less so in the kids. But if anybody tells you, I only ever get a headache on the left side of my head, it is never on the right, never loops from this one spot, never on both sides, officially that's criteria for imaging. Usually with just that indication alone, you're probably not going to find anything, but because it's a little bit of a less common pattern, we're going to be more likely to look for that indication. So those are kind of the main reasons. And it is, when you think about it, kind of a lot of reasons. So it almost sounds like, well, is that everybody? It's not, though. Many patients don't have any of these signs or symptoms. And so they're comfortable with reassurance saying, listen, you have no red flags. You have a completely normal neurologic exam. Your optic nerves are perfect. There's no signs of increased pressure. Let's try treating for a while. Let's try seeing how you do. If you're not getting better, we can always revisit this. I tell people also, even if we don't have imaging today, if anything pops up between now and the next visit, you decide you're nervous, new symptoms are happening, you can always call. We can always order it. This is not like a yes or no forever decision, right? But usually, with reassurance, most people are okay with that. But if there's any of these red flags, we're usually going to be more inclined to image and kind of put the question to rest and
I want to end this series by talking a little bit more, or rather emphasizing more the prevention piece of it. So one thing that I always ask at the end of most of my episodes, especially with subspecialists, is what pearls do you have? Or like, if you could give over any advice if someone wants to avoid ending up like needing somebody like you in their life, like avoid being your patient, what would you tell them?
So I think the the big pieces are, first of all, in terms of lifestyle, the different pieces are all important. Personally, my personal belief is that the most important is caffeine, I think is a huge. I don't think people realize how much caffeine on a regular basis can trigger headaches. And caffeine is sort of a double-edged sword. I almost look at it like a medicine, and the same way that other medicines, when you use them too often, can make your headaches worse. Caffeine can do the same thing. That's why caffeine is actually an ingredient in certain migraine medicines, like, for example, Excedrin has caffeine in it. Caffeine is a drug. And so when you're using it occasionally, for some people that they actually may use it to treat a migraine, they find it helps them. It does help some people. But if you're drinking it on a regular basis, it increases the sensitivity. So it's going to be easier for headaches to come in general. And also when you don't drink it, you're going to be getting maybe caffeine withdrawal headaches. And so I think caffeine is very important. Personally, I also think sleep is a really big piece for me. So getting consistent sleep and being on a pretty good sleep schedule. For a lot of kids and a lot of teens, they are not getting enough sleep. It's a problem. It's mostly because of kind of our society and what we expect of them, but their school days are long. They start very, very early. They have a lot of homework. People are doing tons of after school activities. Then they are on their phones, their social media, their screens. And so for all of these reasons, they're up very late. So I think that for a lot of people, good quality sleep makes a very big difference. The fluid and the hydration, I think, is important, but I don't think it's necessarily as massive as everybody thinks it is. I typically tell people you want your urine to be clean. So we don't necessarily need to obsess about counting your ounces all day long, but when you go to the bathroom, is your urine clean? If it is, you're probably good. If it's yellow, you got to. And kind of sticking with that is I think a good mantra. I think exercise is huge. So exercise helps pretty much everything and has been shown specifically to be helpful as a migraine preventive. And we also know that inactivity has been associated with an increase in migraines. So exercise for general health. I don't talk about weight loss at all. It's a really sensitive topic, and I try and avoid that as much as possible. But just movement, I usually tell people 45 minutes of anything that gets your heart rate up, gets you sweaty, most days of. I just want you to move. Doesn't matter. So I think that is important, and I have seen a lot of people improve when they're exercising, whether it's because it's helping the headaches directly, or it's helping their stress levels, or it's helping them sleep better, or all of it. I don't know, but it helps. And then the diet, we didn't really go into this much. It's a huge question that people have. There are all these foods that are thought of as migraine triggers. Honestly, and if you Google, you'll find a list of migraine trigger foods and all these lists. And especially in kind of olden days, people give lists to every migraine patient, don't eat any. Most of the foods on those lists are not triggers for most people. So I actually am not a proponent of recommending against most of those foods. The only things that have really been consistently shown to be migraine triggers are, like I mentioned, caffeine and alcohol. Alcohol, which hopefully, if we're talking about pediatrics, we're not getting into anyway, but if we are, that is definitely associated with headaches. Besides for that, some people may find that they have a food trigger, but it's really probably less important than most people think it is. And so and a lot of foods on that list are healthy foods that you don't necessarily want people to have. So I typically tell people, keep a kind of a loose eye on things. If you notice, every time we have a barbecue and I have a hot dog, I'm like always getting a headache after a barbecue. Every time we order Chinese food, I always get a headache, right? So like, if you notice something like that, then try cutting out that one thing, see if it makes sense. But for most people, most of those things are not trigger, and I don't recommend avoiding a whole list of things. What I do think is important for diet in general is, first of all, eating consistently. So not going huge chunks of times without foods. We know that fasting can be a trigger for headaches. And also eating a well-balanced diet. Probably, especially for some people, maybe some more than others, foods that cause a lot of inflammation in the body may contribute to kind of the inflammatory piece of migraine that happens in the brain. And so things that are generally associated with inflammation, so like highly processed foods, lots of artificial dyes and sweeteners and sugar, for some people seems to make a difference. For other people, it does. So it really depends on the person, but kind of a focus on whole healthy foods that have lots of nutrients, lots of antioxidants, dark green leafy vegetables, berries. So kind of like focusing on adding in healthy stuff and having less of the highly processed stuff, I think is a good idea, probably for everybody, but for migraine patients, for many of them, it does make a difference when they kind of clean it up a little bit, but I don't think it needs to be highly restricted, and you don't want to get into that place. People ask about gluten and dairy. That comes up a lot. It's a common question. Celiac disease, for sure, can cause headaches. So if somebody truly has celiac disease, gluten, it can cause headaches. Outside of true celiac disease, it's probably uncommon for gluten to cause headaches. Cutting out gluten is really, 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 really hard, especially for kids. A lot harder than people think it is. I think also can, put a lot of extra stress on a kid who wants to go to a birthday party and have cake with their friends. And like, we don't want to be making them the other end, making them different and causing this extra stigma that doesn't necessarily.
We always want to be like very, very, I think, careful when we recommend, even trialing, like cutting something out of a diet. Yeah. So obviously, like somebody with celiac, yes, we need to get gluten out of their diet. But I agree with your hesitation to make that blanket recommendation to like try it and see if it makes your headache better, especially when we know there's really no evidence that that's the case. It's a huge deal. Yeah.
It's not a little thing. Like, just don't eat gluten for a while. It's a big deal. So usually we only go that route if they're not getting better and nothing's working. And we're like, let's just try this for 2 months and see. You know what I mean? So generally a focus on well-balanced whole foods with lots of nutrients and less of the processed stuff. Yeah. And that's it. We don't want to make you super crazy and nitpick, to great detail. So those lifestyle things, I think, like in terms of pearls, those things are important and a good idea. The other sort of pearl would be treat your headache acutely, aggressively, get on top of it, have a note for school, like with the patient's meds on it, that it can be given to the nurse so that they're allowed to keep their meds at school. It's acceptable for them to raise their hand, go to the nurse, take their medicine, go back to class. So we want to minimize, how like any interference with their daily function, right? So like the default shouldn't be anytime I get a headache, I go home, right? We don't want that. The more that happens, typically the worse they do. So we want to have a good plan in place for if I get a headache, my medicine is ibuprofen, 300 milligrams. It's at the nurse. My teacher knows that if I say I have a headache, I'm allowed to go to the nurse. No one's giving me an issue about it. No one's not believing me. We all know. I go to the nurse. I take my medicine. I drink some extra fluids. I maybe rest for a few minutes, and then I go back to class. Having sort of that expectation for a good plan laid out in advance so that we know what to do when it happens and we're all kind of on top of it, I think helps, neurologically. So those are like really the main things, I think. And then, after that, we start to get into the nitty gritty of each specific patient.
Really, really comprehensive and concrete, and I think overwhelmingly doable goals and things to try and work on that I think are probably helpful and beneficial for like wellness and health overall. And it never ceases to amaze me how the general recommendations that like people tell me for like prevention and regardless of the specialty, with the exception of trauma, because they give very different recommendations, like the recommendations are really the same. So really like headache prevention, the steps that you do and the things that you try and achieve, I think are anyway, like you were saying, great for overall health and longevity. And we absolutely want to instill those habits early on. And so I always encourage kids and adolescents to like take control of your health and wellness and how you spend your time and really like solidify good habits. So then you don't end up with as a migraine patient when you're an adult. Dr. Hagler, I want to thank you so much for your time and for doing a deep dive with me on all things headache today.
Thank you so much for having me.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.